Hey everybody, and welcome to the Student Physical Therapist Insider Access page. Uh, for this month's Insider Access post, I wanted to talk a little bit about working on the impairment of TMJ opening. Um, as if I don't know if you're seeing a lot of TMJ in your clinic, but if you're not, it's possible that you have patients with cervical spine dysfunction that have a component of affected TMD as well. Um, One of the common presentations for people with TMJ dysfunction includes a limited mouth opening. In general, when you're assessing for normal mandibular depression, they should be able to take 3 to 4 knuckles of the PIP and fit that in their mouth. So you could have them do a self test of opening their mouth and just testing with their own hand, or you can take the use your goniometer and measure approximately 40 to 50 millimeters of depression. Like I said, typically most people with TMJ dysfunction are missing that kind of motion due to having a pain at that end range. So there's a couple ways to work on trying to improve that TMJ mobility. And one of the more common ones, I think if you're taking more like the Rockabato approach, is probably just manual stretching. So you can have them just kind of block their upper maxillary inside, teeth and then depress their mandibular teeth and just do, a couple minutes of holding or 30 seconds on, 30 seconds off, trying to just stretch that. You will get an improvement in mobility regardless. One of the concerns about that potentially, if you just focus on that, is that you're going to be forcing someone that has an anteriorly displaced disc to push it even farther anteriorly. So if you find that your patient is presenting with that, instead of focusing just on stretching to open their mouth, you can first work on the motor control aspect so that they maintain the normal ratio of roll to translation when you're talking about the mandibular condyle to the articular disc. And you do that with just tongue on the roof of the mouth and just open and close the mouth. Rockabato recommends 6 repetitions 6 times a day. So just like that. And as that control improves and they're getting less clicking in their TMJ, you can start transitioning to trying to get further mobility. Something that I like to use that I've learned from other people that like working with repeated motions is repeated protrusion. So just like that. Um, if you think about when you're opening your mouth, the end part of the motion is protrusion, or in that translation of the condyle anteriorly. You can actually feel it when you're palpating the TMJ. Now think about also our most common position, so forward head posture. If you palpate or just pay attention to how your mandible feels while going through that motion, you should actually feel that the mandible retrudes while you get in the forward position. So if you think about this in the lumbar spine, most people spend excessive time in flexion and lose extension. Well, when it comes to cervical spine and mandible, um, the cervical spine spends excessive time in protrusion or protraction, forward head posture, and thus the mandible spends excessive time in retrusion. So to do that repeated motion for it, we want to be in cervical retraction and then TMJ protrusion. Now, what can happen is that when you're assessing your patient with opening their mouth, they may deviate to one side. And that's typically due to a hypomobile joint, one more so than the other on that side. So what's recommended is when you're doing your repeated protrusions, you just add a little wiggle on both sides. What that's doing is trying to mobilize the different aspects of the capsule on each side. Um, in general, the way that I treat my patients is that I kind of include all of these in my TMJ patients, so I make sure that they're doing the motor control exercise regularly throughout the day. If they're limited with opening their jaw, I don't typically start with the stretching. I'll prefer to start with the repeated protrusion because I feel like they're going to get less of that clicking or forcing the disc more anteriorly. I want them to do as much as they can to keep the disc where it's supposed to be. In your more chronic cases where you're just focused on getting the mobility, that's when you're going to be doing the manual stretching more so. Uh, and like I said, definitely reinforce it with the motor control training. You can add some isometrics as well, different directions. But that's kind of the basis for treating specific to the TMJ. Do not forget your other upper quarter impairments like your likely dysfunctional deep neck flexors of the cervical spine, scapular stabilizers, thoracic mobility, cervical mobility. All those aspects are essential for treating your patients with temporomandibular dysfunction. If you have any questions specifically about addressing something else with the TMJ, feel free to contact me and I'd be happy to answer.